MS support, IVIG treatment for ADEM explained. Acute Disseminated Encephalomyelitis, or ADEM, is an inflammatory condition affecting the central nervous system. It can sometimes be confused with multiple sclerosis due to similar symptoms. However, ADEM usually presents as a single episode and often follows an infection or vaccination. The primary treatment for ADEM focuses on reducing inflammation through immunosuppression. One treatment option for ADEM is intravenous immunoglobulin, commonly known as IVIG. This therapy is considered a second-line treatment, especially when high-dose corticosteroids, which are the first-line therapy, are not effective or cannot be used. IVIG consists of pooled antibodies from healthy donors. It helps modulate the immune response, reducing the autoimmune attack on the nervous system. Studies have shown that IVIG can improve neurological function in both children and adults with ADEM. In cases where corticosteroids do not work, IVIG has been reported to lead to rapid recovery, sometimes within days of starting treatment. The typical dosing for IVIG involves an induction phase of 2 grams per kilogram of body weight, given over 2 to 5 days. For patients with recurrent ADEM, maintenance doses of 0.42 to grams per kilogram may be administered every 4 to 6 weeks. IVIG has been effective in reducing neurological deficits and may help prevent relapses in patients with multiphasic or recurrent ADEM. Magnetic resonance imaging findings often show improvement that aligns with clinical recovery after IVIG therapy. When comparing ADEM to multiple sclerosis, it is important to note that ADEM typically occurs as a single episode. However, some patients may develop symptoms similar to ADEM and later be diagnosed with MS if they experience relapses. While IVIG is not a standard treatment for MS, it has been used off-label for steroid-resistant relapses in some cases. This highlights the differences in treatment strategies between ADEM and MS, as MS often requires long-term immunomodulation or immunosuppression. In practical terms, IVIG is usually considered when corticosteroids fail or are not suitable for the patient. Treatment decisions should be personalized, taking into account the patient's age, the severity of the disease, and how they have responded to previous therapies. It is essential to monitor for potential side effects of IVIG, which can include allergic reactions or kidney issues. Since ADEM can mimic MS, patients receiving IVIG for ADEM should have follow-up care to monitor for any signs of progression to MS or other demyelinating disorders. In summary, IVIG is a valuable treatment option for ADEM patients who do not respond to corticosteroids, offering significant potential for recovery and relapse prevention. Understanding the role of IVIG in ADEM can help clarify the differences in diagnosis and treatment strategies between these related but distinct conditions. Always consult with a neurologist experienced in demyelinating diseases for personalized medical advice.